Good morning. I'm Dr. Timothy Murray. I'm the director of the Ocular Oncology Service at the Bascom-Palmer Eye Institute. I'm a professor in ophthalmology and radiation oncology at the University of Miami Miller School of Medicine. I had the pleasure to be the invited speaker for the Pan American Research Day for 2012 at this year's ARVO, and I'm going to share the content of that presentation with you with a focus on ocular oncology and a particular insight into the management of children with intraocular retinoblastoma. For this talk, I have no financial disclosures, but I will be discussing the off-label use of both drugs and devices and potential off-label use of surgical procedures. Retinoblastoma is the most common primary intraocular malignancy in childhood. It affects between 1 in 12,000 and 1 in 15,000 children. Current treatments for this disease began with enucleation surgery, shifted to systemic chemotherapy, included external beam radiation therapy, and have moved toward focal therapies with an attempt to save the child's life, retain the eye, and preserve vision. Unfortunately, even today, advanced retinoblastoma tumors are common at presentation, and advanced tumors are the most difficult to control, with failure rates that range from the Bascom-Palmer Eye Institute failure rate of approximately 20% up to failure rates of 80% around the United States. Failure is almost universally associated with advanced disease and either vitreous seeding or subretinal seeding. The presenting signs are important for us to recognize immediately, and from an ophthalmologist's perspective, these signs are very standard. Approximately 60% of children present with leukocoria, the classic cat's eye pupil. About 20% of children, 1 in 5, will have a secondary strabismus, and less than 10% of children will present with a red painful eye. It's important to recognize that this diagnosis is often delayed, and it's seen rarely on a well baby examination in less than 3% of the children. As you can see here, some excellent clinical examples of presenting leukocoria. In the slide to your upper left, this child's left eye has classic leukocoria with the white cat's eye pupil. In the slide to your lower right, you'll see here that the left eye has a complex leukocoric presentation, but also complex secondary strabismus with the left esotropia. On your left, you see the Christmas photograph of the child that presented to us at Bascom-Palmer. His family wasn't concerned about the leukocoria you see in his right eye because their dog Brutus had leukocoria in the left eye. Unfortunately, Brutus's leukocoria, the dog's, was secondary to a traumatic cataract, while the child's leukocoria in the right eye was from complex advanced retinoblastoma. As you might expect, this led to a significant delay in the evaluation and diagnosis of this child. I'd like to give you some clinical examples of retinoblastoma today to show you what this looks like in presentation from very early small tumors to very advanced large tumors. There are 2 staging classifications for retinoblastoma. The classic is the Rees-Ellsworth classification, which evaluated tumors based on their clinical presentation and their expected response to external beam radiation therapy. With the shift from external beam radiation therapy to systemic chemotherapy, we instituted a new classification scheme, the ICR classification, or the International Classification of Retinoblastoma. Early tumors in Rees-Ellsworth are typically stage 1 through 4, and in the ICR classification are stages A, B, or C. Tumors show a translucent white-gray fleshy mass within the retina. There are dilated intratumoral retinal and tumor vessels, and there may be microcalcification. You see the low magnification and high magnification of this child who presented with a right macular retinoblastoma, the classic microcalcification, the small white areas within the tumor. You see the dilated vessels within the tumor and in the surface overlying retina, and you see the salmon fleshy appearance of the intraretinal tumor.